Dr. Ken Landau. Thanks for watching. Let's talk about infectious mononucleosis, commonly called either just mono or mononucleosis. For most people, the term mono is synonymous with the Epstein Barr virus. Now, the overwhelming majority of people, more than 90%, who are infected with EBV, Epstein Barr virus, they're asymptomatic. When symptoms do develop in the 5 to 10% of people who are symptomatic, it typically presents as a classic triad of fever and pharyngitis or sore throat and enlargement of the lymph nodes, typically in the neck, and that's all associated with peculiar increase in a type of a white blood cell known as lymphocyte that looks funny. Other terms for the condition, a kissing disease or glandular fever. But it's important to realize that the syndrome mononucleosis can be caused by a variety of different infectious agents. So, for instance, adenovirus or herpes simplex virus for the first time you become infected, that could mimic mononucleosis. So too with the human herpes virus number 6 or the roseola virus, 6th disease, or toxoplasmosis or cytomegalovirus or HIV. It's often confused with common cold or a strep throat infection or influenza or hepatitis. Now, interestingly, the newborn acquires antibodies from the mother, so is protected for the first year of life. Then, depending on a variety of circumstances, up till about age 15 or 18, somewhere between 20 and 80% of people are going to acquire the virus, but they're not going to typically have symptoms. They may have symptoms, but typically they don't have symptoms. The likelihood of infection varies with the geographic region, race, ethnicity, the socioeconomic status and crowding, and whether you share a bedroom or not, whether you attend daycare center. So if we look at people between the ages of 16 and about 15, it's more common in African Americans and Hispanics than it is in Caucasians. Most of the people are not going to have any symptoms, but some people do, and as a matter of fact, the first description of what we now refer to as mononucleosis was from a pediatrician in Russia in the late 1800s. Well, the Epstein Barr virus is a herpes virus. It's human herpes virus type 4. And by age 30, about 95% of people have been infected. Once you're infected, it lasts forever inside. You have a lifelong latent infection. In this case, it survives in the B lymphocytes. That's a type of a white blood cell. You have a persistent low-grade replication of the virus, and it can be shed intermittently into the pharyngeal secretions, into the saliva, so it's potentially transmissible. Well, how do you get it? Well, it's typically through intimate contact, typically deep kissing, sometimes sneezing or coughing. It's possible through the semen or vaginal secretions or even use of shared utensils. It's unknown how pre-adolescents become infected, but it's assumed that it's from shedding of the virus from their parents or their siblings as they're either infected for the first time or during the periodic shedding. During the initial infection, an individual has a significant increase in the viral titer, has more than 60,000 copies of the virus in the saliva per milliliter of saliva. During reactivation, the number is much less. It's only about 2,000 or 3,000 or 4,000 copies. But once you're infected, you can have this periodic reactivation of the virus up to 30% of the time. Now, the viremia, the virus in the bloodstream, that rises about 2 weeks before the onset of the illness. You can spread the virus for weeks before the symptoms develop. And with clinical illness, that's at the time of peak transmissibility. That's when you have the highest viral titer in the bloodstream and in the saliva, in the oral cavity. Incubation period for infectious mononucleosis, Epstein Barr virus, is about 4 to 6 weeks. We don't know what the duration of contagiousness is. It seems to be highest in the first 6 weeks after you have the acute infection, but it possibly can go on for months to even a year or more after your infection. In the prepubertal years, even though it's typically thought of as being asymptomatic, it might present with non-specific flu-like symptoms, maybe a sore throat or mild pharyngitis with or without tonsillitis. But it seems that people who are at most at risk, those are the individuals between ages of about 15 and 24. Their incidence of infection is about 48 per every 1,000 individuals, as opposed to the overall population, all ages, where it's only about 5 in every 1,000 individuals. Overall, about 10 to 20% of EBV negative individuals every year are going to convert to positive. The incidence in teenage years seems to be decreasing slightly recently. Incidence in males and females is the same. There's no seasonal variation. It seems that if we look specifically at people who initially are exposed to the virus, we're going to have clinical manifestations. Infectious mononucleosis is going to develop in about 15 to 20% of teenagers. But if we look at young adults, it's going to be about 40%. Now, there are two different presentations. You can have either the sudden onset of a sore throat, swollen neck, and enlarged lymph nodes, worst ever sore throat you ever had, or it could be a more subtle condition that gradually develops, where you complain of malaise and fatigue and body aches. That's the typical presentation. Relatively slow, gradual onset, non-specific prodrome that lasts for a week or two where you don't feel well. Then you develop the fever and the chills and the malaise. But that's common with any kind of viral infection, rhinovirus or coronavirus, multiple other viruses, typical viral pharyngitis or the common cold. So you go to see the doctor who assumes you have a bacterial infection incorrectly and gives you some antibiotic. That's all there is. But then, depending on what the antibiotic is, you might have some complications. It's interesting that a significant number of people who develop mononucleosis have unusual fatigue. They can sleep or spend 12 to 16 hours a day in bed, and they still feel tired. Sore throat occurs in almost everyone who has infectious mononucleosis. More severe than bacterial tonsillitis, tends to be at its peak for about 3 to 5 days. Then it gradually subsides over about 7 days to 10 days. In some individuals, it can last actually more than a month. Tonsillar enlargement, you can even have an exudate that appears white on your tonsils, even covers the back of your tongue. That's different from the speckled appearance that occurs with bacterial tonsillitis, or just the redness without any exudate that occurs with viral pharyngitis. Those problems tend to last for about 2 to 4 weeks. About half of the people have a fever over 100.4. That lasts for up to around 2 weeks. The swollen glands occur in about 3/4 of individuals. Can occur in the neck, either in front of or behind the neck muscle. Sometimes people can even develop swollen nodes in the underarm area or even in the groin. That differs from bacterial tonsillitis, where the swollen nodes are just in the front part of the neck. Fatigue is present in somewhere around 2/3 of the individuals. They just have a general feeling of not being well, and that can persist for more than a month in 25% of individuals who are infected with infectious mononucleosis, who contract the actual condition. It can take several months, 2 or 3 months, for them to get back to normal. Sometimes we have petechiae, or little blood spots on the roof of the mouth, 25 to 50% of individuals. And then we can have an enlarged liver or spleen. That can occur each in about 7, 8, 9% of individuals. Headache is present in about 50% of individuals. Have the problem with loss of appetite in half of the people. Goes along with slight weight loss. And up to 20% complain of nausea or vomiting or abdominal pain. Rash typically is not present unless you saw the doctor and you got a prescription for ampicillin or amoxicillin. If you did, chances are almost 100% you're going to get a rash that looks like the measles are going to be all over your body. And some people, rarely, may develop jaundice or difficult time breathing or anemia or irregular heartbeat. Children are at highest risk of airway obstruction because of the enlarged tonsils. So it seems that is the cause of most hospitalizations for individuals with infectious mononucleosis. Occurs about 1 to 3% of children. Respiratory stridor, and they sort of develop a cyanotic appearance to the skin, and they breathe very rapidly. Treatment is steroids. Steroids bring the situation under control within a period of about 12 to 24 hours. If we look at people who are between the ages of, say, 18 and 22, after their initial contact with the virus, about 75% of those individuals are going to develop clinical mononucleosis, the typical infectious mono. About 15% of individuals are going to develop atypical symptoms. About 10% not going to have any kind of symptoms. Symptoms are unusual in older individuals because they're mostly immune from their prior infection. But some people, if they haven't contacted the virus before, they're going to develop some sore throat that tends to be relatively mild. Maybe they have some mild enlargement of the lymph nodes. But people, once they get to be age 40, if they contact the virus for the first time, then they may be more symptomatic. And we talked about the enlargement of the liver, enlargement of the spleen. Well, people develop a modest degree of hepatitis. About 75% of them going to have a subclinical increase in the liver function tests. Maybe about 5%, 1 in 20, going to present with overt hepatitis. About 5% may become jaundice, the skin can turn yellow. But of more importance is splenomegaly. Nobody ever seems to think about the spleen. And it becomes enlarged, often without clinical manifestations. So the doctor doesn't even notice it. But if we were to do an ultrasound examination, almost all people with mono are going to develop an increase in the spleen. And that causes the potential for a very significant complication. Because once the spleen is enlarged, it could rupture, especially if you do anything that increases the pressure on the abdomen. So you can increase the pressure by rowing or weightlifting, but you also could put pressure on the liver, on the spleen rather, if you happen to be engaging in some sort of physical contact activity, maybe wrestling or diving or basketball or football. That predisposes the spleen to rupture. So it's recommended that if you have mono, you should not engage in any physical activity. Don't do anything rough. Don't do anything that's going to increase the pressure in your abdomen for anywhere between 3 and 24 weeks. No overall guidelines have been published, but it's pretty much agreed on by most people that after all of the symptoms go away, once you're afebrile, once your energy is returned to normal, you have no other abnormalities related to mono, then you should wait 3 more weeks before you engage in non-contact sports, and probably up to around 5 weeks before you engage in contact sports, before you go back to play football. Now, there's the chronic fatigue syndrome. Chronic fatigue syndrome develops after mono in a significant number of people. People have disabling cognitive features. They have some musculoskeletal features. Otherwise, they're unexplained, last for more than 6 months. There's severe impairment in daily function. And the question is, what is the relationship of infectious mononucleosis, the Epstein Barr virus, to the chronic fatigue syndrome? And the answer is there does not appear to be any. But there is a chronic active Epstein Barr virus infection that occurs mostly in Japan and East Asia, where the symptoms last for more than 3 months. And instead of infecting the B cells, the B lymphocytes, in this condition, the Epstein Barr virus affects the T lymphocyte, different kind of lymphocyte. And this can be a fatal condition. And it requires a hematopoietic stem cell transplant. Actually, at the NIH, all but 1 patient died if they weren't transplanted over a period of about 6 years. Well, complications of the disease, we have encephalitis and meningoencephalitis and seizures and optic neuropathy, optic neuritis, sudden hearing loss, have facial paralysis that looks like Bell's palsy, but it's due in this case to the Epstein-Barr virus. Have Guillain-Barré syndrome, and we have the obstruction of the airway that we mentioned that can occur in children. Have hemolytic anemia, or a decrease in the number of platelets. We call that thrombocytopenia. And interestingly, there's a definite association of the Epstein Barr virus with either Burkitt's lymphoma or nasopharyngeal carcinoma or Hodgkin's lymphoma or non-Hodgkin's lymphoma and gastric carcinoma. It's estimated that there are probably more than 200,000 cases of cancer every year due to infection with the Epstein Barr virus. And interestingly, multiple sclerosis seems to have some sort of association with EBV infection. So the incidence of multiple sclerosis begins to increase with adolescent infection. It peaks when infection occurs between the ages of 25 and 30 years of age. Then it declines so that if your first infection is after age 60, you're not at risk. And it seems that multiple sclerosis does not develop in people who have not previously contacted the Epstein Barr virus. So the Epstein Barr virus is present in about 100% of the people with multiple sclerosis. Now that doesn't mean that it's a risk factor or it's a definite prerequisite. We don't know what the association is, but that's the statistical association. Well, if we look overall at infants, they seem to have a relatively higher risk if they happen to be infected relatively early with either a complication of Burkitt's lymphoma or the nasopharyngeal carcinoma. How do we diagnose the condition? Simple blood test. It's a white blood count, differential. It's unlikely if the lymphocytes are less than 4,000. If the lymphocytes less than 4,000, you have a 99% chance that you don't have the condition. Typically, the lymphocytes are increased, and oftentimes we have more than 10% of those lymphocytes that are atypical. We diagnose the condition with a mono test, a monospot test, heterophile antibody. It can be negative in up to 25% of adults during the first week of symptoms, but it's still the best test because it's fast and inexpensive, and it's up to 90% accurate. But it's not recommended for screening because of the poor sensitivity. We have the 25% negative in the first week. We have the 5 to 10% negative in the second week. And 5 to 10% of the people don't develop a positive reaction to the monospot test or the heterophile antibody ever during the course. Now, it seems that once it's positive, about a year later, it's going to become negative. And interestingly, has nothing to do with the antigens or the virus itself. It seems to just be one of those peculiarities. And if a person happens to be less than 4 years of age, well, at least around half of the people are not going to develop a heterophile antibody when they become infected. So, what do we do if we really think that the person has mononucleosis, but the heterophile is negative? Well, we can do some other tests that are fancier and more expensive, but for the overwhelming majority of people are not necessary. Those are the tests to antibodies to see if they've developed to the viral capsid antigen or the nuclear antigen or the early antigen, and all of those are available in any routine laboratory. And sometimes we can do a polymerase chain reaction, PCR, real-time PCR. And we can actually find the viral product right in the saliva. Well, can a person be genetically susceptible? Yeah, you could have a certain increased susceptibility because of a genetic inheritance. What do we do if you're infected? How do we treat you? You're symptomatic? Well, tell you to rest, but not prolonged bed rest, because otherwise that deconditions you. You want to be hydrated. You want some analgesia, some pain medicine if you have a sore throat, or you can treat it with cold dishes or frozen desserts. Gargle with some salt water. You can take medicine to reduce the fever if it's elevated. You want to stay away from amoxicillin or ampicillin because chances are that'll cause a rash. Now, since it's a herpes virus, what about acyclovir? Does that work? For the most part, no. What about valcyclovir, Valtrex, or another one in the family called ganciclovir? Well, they have some promise, especially in people who have very severe mononucleosis or people who are immunosuppressed, maybe immunosuppressed because they have some other disease or cancer, or maybe because they're taking medicine that suppresses the immune system. Well, those medicines, the Valtrex and the ganciclovir, they can decrease the viral shedding, but they don't decrease the illness. But they might help if a person has complications like the hepatitis or the meningitis or some of the blood complications. Steroids are very frequently used, cortisone, prednisone, but it has too many side effects and it doesn't seem really to work, doesn't seem to improve the overall condition. It helps the sore throat a little bit, but only for about 12 hours, so it's really not worth taking it, and it doesn't seem to be any better than just a simple analgesic. It is important to take the steroids, however, if a child develops some of those respiratory impairments that we talked about before. So just remember, the virus is going to stay dormant in the system forever, and it periodically is going to reactivate. So if you happen to be between the ages of about 15 or 18 and up to about 24, be a little bit careful in some of your activities because you may well be rewarded by developing infectious mononucleosis. The condition, by the way, first described in the medical literature, or a condition like it, in 1885 by a Russian pediatrician, Neil Filatov, reported it as an infectious process, called it just idiopathic adenitis, means swollen glands. And then in 1920, the term mononucleosis was coined, and it was from the bulletin of the Johns Hopkins Hospital. And then we go on from there and actually linked the virus to infectious mononucleosis in 1967 when a worker at Children's Hospital in Pennsylvania, in Philadelphia, actually developed the mononucleosis after working with the virus. And some astute clinicians, astute researchers, linked the two together because fortunately her blood was available both before and after the infection. So they did find some antibodies to it. So remember, that's the story about mononucleosis, typically caused by Epstein Barr virus, but not all cases of mono are due to Epstein Barr virus. Symptoms tend to occur mostly in adolescents and young adults. Preteens usually don't develop any symptoms. Older adults tend to be immune because of exposure during their earlier years. Almost everybody over age 30 has been exposed to Epstein Barr virus, part of the herpes family. We know that the symptoms typically are just sore throat and fever and some swollen glands, often with significant fatigue. Right now, we don't have any specific treatment available other than rest and hydration, and sometimes an aspirin or acetaminophen. Typically, you're going to get better after about 2 to 4 weeks. And for the overwhelming majority of people infected, that's the whole story. It's 2 to 4 weeks, and that's it. Don't have any other kind of complications. And the chronic fatigue syndrome, not related to Epstein-Barr virus. Anyway, thanks for watching. If you enjoyed the show, please tell a friend and consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.